Okay, sir. Good evening, sir. Start chedama, sir.
Okay, start with them.
Sir. Good evening, everyone. Let us begin today's session with Omkaram. Let us now continue with the NMO mantram. Natvaham kamahe rajam, na swargam na punarbhavam, kamahe dukkha taptanam, praninamurti nashanam. A warm and heartfelt welcome to all the participants of NMO AP's Med-Katalyst Foundation Revision Series. Today is the day 7 of 15-day Rapid Revision Series, an initiative aimed to strengthen the fundamentals of first-year MBBS students. It is our privilege to have Dr. Siva Sankar sir with us today. We sincerely thank you, sir, for graciously accepting our invitation. Sir will today be discussing endocrine and acid-base balance and neurophysiology topics. With great respect, I now request Dr. Siva Sankar sir to kindly take over the session and guide us with his valuable insights.
Okay. Good evening, everyone. యాక్చువల్గా రివిజన్ సెషన్ కదా, రివిజన్ లాగానే వెళ్ళిపోదాం. ఇవన్నీ టాపిక్స్ అన్ని మనకు తెలిసిందే. థైరాయిడ్ గురించి, యాసిడ్ బేస్ బ్యాలెన్స్ గురించి అండ్ న్యూరోమస్కులర్ జంక్షన్ గురించి మనకు తెలిసిందే. అన్నిటినీ బ్రీఫ్గా చూసుకుంటూ వెళ్ళిపోదాం. నోట్స్ రాసుకోవాల్సిన అవసరం లేదు. కావాలంటే పక్కన పెన్ను పేపర్ పెట్టుకోండి, కొన్ని పాయింట్స్ నోట్ చేసుకోవడానికి యూజ్ అవుతుంది. అండ్ మన సింపుల్ లాంగ్వేజ్లోనే వెళ్ళిపోదాం. ఒక సీనియర్ పక్కన కూర్చుంటే ఎలా చెప్తాడో, ఫ్రెండ్ ఎలా కూర్చుంటాడో అలానే నేను చెప్తా ఉంటాను. మీరు చెప్పేది వింటూ ఉండండి, స్క్రీన్ చూసుకుంటూ ఉండండి. అండ్ అంతకన్నా ముఖ్యంగా ఏంటంటే మీరు మైండ్లో రివర్స్ చేసుకుంటా ఉండండి, ఎందుకంటే ఇవి మీరు చాలాసార్లు ముందే చదివిందే. జస్ట్ రివర్స్ చేసుకుంటూ వెళ్ళిపోదాం. ఓకే, అండ్ స్టార్ట్ చేద్దాం ఇప్పుడు. బయోసింథసిస్ ఆఫ్ థైరాయిడ్ హార్మోన్స్ అండ్ యాక్షన్స్. యాక్చువల్లీ మీకు ఎగ్జామ్లో ఏ క్వశ్చన్ వచ్చినా కానీ క్వశ్చన్ని కొన్ని వెంటనే రాయడం స్టార్ట్ చేయకుండా పేపర్ చదివి క్వశ్చన్ని ఎలా రాసుకోవాలో కొంచెం ప్లాన్ చేసుకొని చేస్తే బెటర్. ఇప్పుడు ఫర్ సపోజ్ బయోసింథసిస్ ఆఫ్ థైరాయిడ్ హార్మోన్స్ అండ్ యాక్షన్ అన్నాడు. మీకు ఎస్ఏ క్వశ్చన్ వస్తే ఎస్ఏ లాగానే ఫస్ట్ స్టార్టింగ్ నుంచి ఫస్ట్ డెఫినేషన్ ఉంటే డెఫినేషను, లేదంటే ఫస్ట్ దాని గురించి అనాటమీ కొంచెం ఇంట్రడక్షన్, ఆ తర్వాత అనాటమీ, తర్వాత థైరాయిడ్ హార్మోన్ ఎలా ప్రొడ్యూస్ అవుతుంది, ప్రొడ్యూస్ అయిన తర్వాత అది ఎలా రిలీజ్ అవుతుంది, రిలీజ్ అవడానికి స్టిమ్యులస్ ఏమైనా ఉందా, స్టిమ్యులస్ ఎక్కడి నుంచి వస్తుంది, ఆ తర్వాత నెక్స్ట్ రిలీజ్ అయిన థైరాయిడ్ హార్మోన్ ఎక్కడెక్కడ యాక్ట్ చేస్తుంది, ఆ తర్వాత నార్మల్ ఫంక్షన్ ఏం చేస్తుంది, ఆ తర్వాత ఏమన్నా ఆ ఫంక్షన్లో ఏమన్నా లోపాలు ఉంటే ఏమన్నా డిసీజ్ వస్తాయి. ఇలా ప్రతి క్వశ్చన్ని ఆలోచించుకొని ఒక స్టెప్ వైజ్ చూసుకుంటే, అది చదువుకునేటప్పుడు కూడా చూసుకుంటే అది యూస్ అవుతుంది. సో మనం అదే వేలో ఈరోజు డిస్కషన్ చేసుకుందాం. స్టార్ట్. ఇంట్రడక్షన్. థైరాయిడ్ గురించి మనకు తెలిసిందే. థైరాయిడ్ లార్జెస్ట్ గ్లాండ్ ఇన్ ద బాడీ అండ్ అది సెక్రెట్ చేస్తుంది థైరాక్సిన్ అండ్ ట్రైడోథైరోనిన్. యాక్చువల్గా T3 T4 అంటారు కదా, థైరాక్సిన్ T4 అంటారు, ట్రైడోథైరోనిన్ T3 అంటారు. సో వీటి మెయిన్ ఫంక్షన్ ఏమంటే ఇంక్రీజ్ ఇన్ ద మెటబాలిక్ రేట్. బాడీలో మెటబాలిక్ రేట్ ని పెంచడానికి ఇది ఉపయోగపడుతుంది. అంటే మోస్ట్ ఆఫ్ ద టిష్యూస్ లో, మోస్ట్ ఆఫ్ ద సెల్స్ లో మెటబాలిక్ రేట్ ని ఇంక్రీజ్ చేయడానికి ఈ థైరాయిడ్ హార్మోన్స్ అనేవి యూజ్ అవుతూ ఉంటాయి. నెక్స్ట్ దీనికి స్టిమ్యులస్ ఏంది? దీనికి స్టిమ్యులస్ అనేది యాంటీరియర్ పిట్యూటరీ నుంచి ప్రొడ్యూస్ అయిన TSH, థైరాయిడ్ స్టిమ్యులేటింగ్ హార్మోన్ అనేది స్టిమ్యులేట్ చేస్తుంది థైరాయిడ్ ప్రొడక్షన్ కి. అండ్ థైరాయిడ్ గ్లాండ్ లోనే క్యాల్సిటోనిన్ ప్రొడ్యూస్ చేసే గ్లాండ్ టిష్యూ గానే ఉంటుంది. ఆ క్యాల్సిటోనిన్ అనేది కాల్షియం మెటబాలిజం లో హెల్ప్ చేస్తూ ఉంటుంది. ఫంక్షనల్ అనాటమీ మనకు తెలిసిందే. థైరాయిడ్ గ్లాండ్ ఎక్కడ ఉంటుంది? నెక్ కి ముందు పక్కల థైరాయిడ్ గ్లాండ్ ఉంటుంది. ఎట్ ద లెవెల్ ఆఫ్ C5 to T1 రెండు లోబ్స్ ఉంటాయి. 2 lobes will be there. Both of those will be connected by thyroid isthmus. అండ్ మీరు హిస్టాలజీ తీసుకుంటే థైరాయిడ్ లో మెయిన్ పార్ట్ ఏంటంటే ఫలికిల్స్ అని ఉంటాయి. ఫలికిల్స్ అనేవి యూనిట్స్. ఫలికిల్స్ ఏం లేదు, స్పెరికల్ స్ట్రక్చర్స్ ఉంటాయి. ఆ స్పెరికల్ స్ట్రక్చర్ లో గ్లాండ్ చుట్టూరు థైరోసైడ్స్ అనే సెల్స్ ఉంటాయి. దాని మధ్యలో కొలైడ్ అనే సబ్స్టాన్స్ ఉంటుంది. అదే థైరాయిడ్ యొక్క మెయిన్ ఫంక్షనల్ యూనిట్ అన్నమాట. అక్కడే మీకు థైరాయిడ్ హార్మోన్ ప్రొడక్షన్ అనేది, ఆ తర్వాత థైరాయిడ్ హార్మోన్ రిలీజ్ అయ్యేది, అవన్నీ అక్కడే జరుగుతుంది. సో సింపుల్ టర్మ్స్ లోనే వెళ్ళిపోదాం మనం. మీరు కూడా నెంబర్ వేసుకుంటూ రివైజ్ చేసుకుంటూ గుర్తు పెట్టుకుంటూ వెళ్ళిపోండి. ఇవన్నీ అంతే. థైరాయిడ్ మెడకు ముందు ఉంటుంది. టూ లోబ్స్ ఉంటాయి. రెండింటిని ఇస్మస్ కనెక్ట్ చేస్తుంది. తర్వాత మనం హిస్టలాజికల్ తీసుకుంటే థైరాయిడ్ ఫాలికల్స్ ఉంటాయి. ఫాలికల్స్ చుట్టూ థైరోసైడ్స్ అనేవి ఉంటాయి. వాటి లోపల కొలైడ్ అనే సబ్స్టాన్స్ ఉంటుంది. కొలైడ్ అనేది యాక్చువల్గా ఒక జెల్లీ లైక్ సబ్స్టాన్స్ ఉంటుంది. ఆ జెల్లీ లైక్ సబ్స్టాన్స్ లో మెయిన్ కెమికల్ సబ్స్టాన్స్ అనేది థైరోగ్లోబులిన్ అనేది ఉంటుంది. ఆ థైరోగ్లోబులిన్ లోనే మన థైరాయిడ్ హార్మోన్స్ అనేవి ఉంటాయి. యాక్చువల్గా ఈ థైరోసైడ్స్ if you want English only, out of Andhra people are there. Okay, I will go with English also. Okay, so thyroglobulin is the main substance will be there where the thyroid hormones are stored. Thyrocytes will produce thyroglobulin. Thyroglobulin will be secreted into colloid. Colloid will produce the thyroid hormones, and the thyroid hormones will be stored in the thyroglobulin. When there is necessity, the thyrocytes will take out that thyroglobulin and divide the produced thyroxine and triiodothyronine. It will take into the cells. From there, it will send it into the blood. Like this, synthesis secretion will be like this. And main substance is thyroglobulin. Thyroglobulin is nothing but a glycoprotein which is having thyroxine. Thyroxine and triiodothyronine. Actually, it will be made up of tyrosine. Amino acid tyrosine is the main substrate for the synthesis of thyroxine hormone. So you can see here, this is a thyrocyte. Left side thyrocyte will secrete thyroglobulin droplets. It will secrete into the colloid. Whenever there is stimulus for the secretion, that from the colloid, thyroglobulin will enter into the thyrocyte. From there, it will be divided. Triiodothyronine and thyroxine, which are binded to the thyroglobulin, will be cut off from the thyroglobulin, and they will be secreted into the blood. You can see the blood vessels here. Into these blood vessels, it will be secreted. Okay, hypothalamo-pituitary axis. Actually, thyroid hormone secrete for the secretion of thyroid hormone. Some stimulus should be there. The main stimulus for the secretion, first the stimulus come from the hypothalamus. Hypothalamus will secrete thyrotropin releasing hormone. From there, that thyrotropin releasing hormone will go to the pituitary gland. The pituitary gland will produce thyroid stimulating hormone, which will go to the thyroid gland, which will stimulate the thyroid gland to produce T3 and T4. That T3, T4 will secrete into the blood. It will go into the circulation and it will act on the peripheral tissue where it will show its physiological actions. And here one thing you have to remember, T3, T4, which are produced from the thyroid gland, they will go to the pituitary gland and hypothalamus, and they will cause negative feedback inhibition of TRH and TSH production. This you have to remember. This is the mechanism you have to remember regarding the hypothalamo-pituitary thyroid axis. Secretion of thyroglobulin from the thyrocytes. आपको already पता है कहाँ where it will be produced. So you already know this. So let us see stepwise what are all the things going on during the production of these thyroid hormones. So thyrocytes will synthesize thyroglobulin. I already told about this. What will be there in the thyroglobulin? Thyroglobulin is nothing but the a glycoprotein containing 70 tyrosine amino acids. Tyrosine is the main substrate for the production of thyroid hormones. And these are the hormones T3, T4. T3 is tetroiodothyronine and T4 is tetraiodothyronine, that is nothing but thyroxine. And sometimes if you see the diagram, there is chance to why this much of big diagram, but it is easy to understand by seeing the diagram. Actually, if you see in the diagram, it is there 3, 5, 3 dash, 5 dash tetraiodothyronine. That means in 3 position, 5 position, 3 dash position, 5 dash position, iodine will be there. That is T4. And in 3 position, 5 position, 3 dash position, if iodine is attached, that is 3. Very simple to remember. If you want, you can remember, or else just you can write T3 and T4. And while producing, most of the percentage, like 93% of percentage is thyroxine is produced, and less than 7% is T3 is produced, and this is released into the blood. First, we will see the steps how it is produced. Iodide trapping. First, we have to catch the iodide which is there in the blood. Thyrocytes will do that work, and after that, oxidation of the iodide ion. Next, organification of the thyroglobulin, coupling of the iodotyrosine residues, release of T3 and T4 into the blood. These are the steps, main steps in the biosynthesis of thyroid hormone. If you want, you can take pen and paper, you can write there so that you can be easily remember these steps. After this, I will detail discuss about these each steps. This is a thyrocyte, basal membrane, apical membrane. This is thyroid follicle. So this is a thyrocyte, basal membrane. What is basal membrane and apical membrane? To understand this, you can see a diagram here. Right. So this is the thyroid follicle. Inside there is colloid. This is the thyrocyte. Outer side of this is basal membrane, and inner side is apical membrane. You can visualize this, the thyrocyte, by seeing this small diagram. So basal membrane is there, apical membrane is there, and thyroid follicle lumen. This lumen is here, this side. So here blood vessels will be there. From the blood, these sodium iodide, actually iodide should come into the cell with the help of sodium iodide symport. Sodium iodide symport will help in taking the iodine into the cell. From there, these iodide should go into the colloid through a protein called pendrin. Actually, pendrin is chlorine iodine antipode. Through that, it will enter into the colloid. From there, that iodide is changed to which will be added to the thyroglobulin. Like this, iodine will be added to the thyroglobulin. From there, the thyroid hormone is produced. Here TG, the thyroid hormone will be there. Whenever is necessary, these thyroid hormone along with TG will come into the thyrocyte. From there, T3 and T4 is released from these thyroglobulin, and this will be released into the cell. Sorry, released into the blood. So these we can see step by step. So iodide trapping with the help of sodium iodine symport, it will go into the thyrocyte, and the energy for this is come from sodium potassium ATPase. So you know sodium potassium ATPase will work by active transport mechanism, and this mechanism is secondary active transport mechanism, because Na plus K plus ATPase will create the sodium concentration gradient outside the cell. So the energy produced by that will helpful for the transport of iodide along with the sodium inside the cell. So this is secondary active transport mechanism. And the pentrin is chlorine iodide counter transporter, which will help in the transport of the iodide from inside the thyrocyte to the colloid and oxidation of the iodide ion. So actually the iodide is not able to attach with the thyroglobulin. So for that it should be converted to nascent iodine. For that the enzyme will helpful is thyroid peroxidase. With the help of hydrogen peroxide, there will be converted into nascent iodine, which will be attached to the thyroglobulin. That is called as organification of the thyroglobulin. So initially MIT monoiodotyrosine will be produced when one iodine is added to it. After that, if we are 3 position, 5 position diiodotyrosine, next 3 position, 5 position, and another tyrosine is attached in 3 dash position, that is T3, sorry. And if you add an 5 dash position also, it will be T4, and reverse T3 also will be produced. Actually, like this, different types of iodotyrosines are produced. Then these have to be coupled with each other. That MIT plus DAT. If you add MIT plus DAT, you can produce T3, and DAT plus MIT, it will form reverse T3. And excuse me, can we remove this NMO Andhra Pradesh? Okay. Coupling of the iodotyrosine residues. These iodotyrosine residues will be coupled together for the formation of these thyroid hormones, which will be stored in the thyroglobulin. Whenever necessity, they will be released into the blood. Release of the T3, T4, already you know how from thyroglobulin these thyroid hormones are released into the blood by the process called pinocytosis. What is pinocytosis? That is cell drinking. From the colloid, thyroglobulin will be drank by the cell into the thyrocyte, and from the T3, T4 are released into blood. After coming into the blood, they will be attached to thyroid binding globulin or transthyretin or albumin. So for the circulation, there should be a binding protein for the stability. From there, it will go to different parts of the body. Actually, T3 is more active than T4, but T4 is produced more because of, actually it will help as circulatory reservoir, temporarily reservoir. You can use it as reservoir. For that future purpose, you can use it. And whenever necessity, T4 can be converted into T3 with the help of deiodinase. Mechanism of action, you know how it works. Actually, whenever T4 comes into the T4 or T3 come into the cell, it will go and attach it to the inside. Actually, you know that thyroid receptors are nuclear receptor. So directly it will go into the nucleus. It will attach it to the receptor called retinoid receptor and thyroid hormone receptor. When it is attached, it will cause some conformational structural changes, and it will form hormone receptor complex, and this hormone receptor complex will go and attach it to the DNA. From the DNA, transcription will occur, and it will cause the production of mRNA. From that mRNA, proteins will be synthesized, which will cause different physiological actions like growth. It will cause the growth of the cells, CNS development, cardiovascular system, and metabolism. Like these physiological activities occurs through this mechanism. Actually, you have to remember this diagram because you will get in exam. So to describe the physiological function, you have to use this diagram. It's easy. Next, physiological functions. It will help in regulation of ion channels, regulation of oxidative phosphorylation, and activation of intracellular secondary messengers like CAMP or protein kinase. On the cellular metabolism, you already know that it increases the cellular metabolism and it will increase the number and activity of mitochondria and increase the O2 consumption, and it will cause calorogenic effect, which will increase the by the metabolism of fatty acids. It will increase the body heat and increase the activity of Na plus K plus ATPase. This will also produce helpful for the generation of heat. Action of the growth. Actually, it will help in skeletal and bone maturation. And if the thyroid hormone is not available during the growth period, it will cause growth retardation. And if it is not available, like decreased production in the fetal life, it will cause decreasing the brain growth and development. It will lead to retarded brain growth and retarded maturation. That is called cretinism. I think you know what is cretinism. So let us see the thyroid hormone actions. Carbohydrate metabolism stimulates the all aspects of carbohydrate metabolism, enhances the glucose uptake, glycolysis, gluconeogenesis, and increase in insulin secretion. Fat metabolism, it increases the free fatty acids in the blood and decrease the cholesterol, phospholipids, triglycerides, all these substances from the blood. Vitamins, increase the vitamin requirement. Basal metabolic rate, increase the BMR. And general features like body weight, decrease the body weight because by increasing the BMR, so much of things will be utilized, so body weight will be decreased. Cardiovascular system, increase the heart rate, increase the cardiac output, increase the force of contraction. Respiratory system, increase the rate of respiration. Gastrointestinal system, increase the motility. CNS, increase the rapidity of cerebration, like brain activity will be increased. Musculoskeletal system, slight increase excites the musculoskeletal system. If it is excess increase, causes the muscle weakness. Endocrine glands, increase the activity. So from this you can understand thyroid gland will help in increasing in the activity of all the systems because it will increase the metabolic activities in the cell. Every cell of the body, it will increase the metabolic activities. So let us see about the disorders. Whenever there is discrepancy in the production of thyroid hormone, what will happen? So if it is increased, hyperthyroidism. If it is decreased, hypothyroidism. Example for the hyperthyroidism is Graves' disease. What will happen in the Graves' disease? There will be autoantibodies against TSH receptor. So thyroid stimulating hormone receptors will be stimulated more. When they are stimulated more production of these thyroxine and T3 will be there. Then the gland activity will be increased several folds. It will cause different physiological actions. Graves' disease, and another one is adenoma. Adenoma means gland tumor. Oma means tumor. Adenoma means gland. So gland tumor. Whenever there is tumor to the gland, increased secretion will be there. Next, hypothyroidism. Hypo means decreased thyroid hormone production. And example, Hashimoto thyroiditis. What will happen in this Hashimoto's thyroiditis? Autoimmunity against the thyroid gland. Because of autoimmunity, autoantibodies will be produced. They will go and attack the gland. It will destroy the glandular tissue. So decreasing in the thyroid hormone production. And endemic colloid goiter. This is actually important thing is what is goiter? Goiter is the enlargement of the gland, usually which is occurred due to decreasing intake. When when there is decreased iodine availability, it will lead to goiter. How it will happen? You can see with this diagram. Actually, you already know this hypothalamo-pituitary thyroid axis. Usually, whenever there is T3, T4, they will be acting on the anterior pituitary to decrease the TSH secretion. Whenever there is low T3, T4, negative feedback will be gone, and anterior pituitary will produce more and excess TSH, and excess TSH will be continuously stimulating the gland, but there is no iodine for the production of thyroid hormone, so colloid will be produced more, but no thyroid hormones. Because of this, thyroid hypertrophy will occur, and you can see in the diagram clearly. So this is how goiter will occur. Next, thyroid myxedema. Due to the total lack of thyroid function, when there is total lack of thyroid function, these myxedema will occur. Actually, these thyroid hormones will help in the fibroblastic activity to control fibroblast activity in control చేయడంలో these thyroid hormones will be helpful. Whenever there is decreasing in the thyroid hormones, these fibroblast activity will be increased. They will produce glucosaminoglycans. They will produce that, and these excessively produced glycosaminoglycans like hyaluronic acid and chondroitin sulfate, they will be accumulated in the body, and they will attract more water, then it will cause swelling of the body. You can see in the diagram, bulging of the eyes, facial swelling, all these features will be there in thyroid myxedema. And you have to remember one thing, thyroid myxedema will cause edema. Which type of edema? Non-pitting edema. Okay. Next. So features of hyper and hypothyroidism, growth and hypothyroidism. So growth will be impaired, and increased thyroid accelerated growth, and activity and sleep. Whenever there is lethargy means so lethargic and increased sleep. Whenever there is brain activity will be there, temperature tolerance. Usually thyroid hormones will produce heat. Because of that, human will sustain. When there is no thyroid hormones, so no heat production, so person is unable to bear with the, సో చలికి తట్టుకోలేకున్నాను అంటారు కదా, సో అలాంటి సిచ్యువేషన్ వస్తుంది. ఇంకోటి హైపర్ థైరాయిడ్, మోర్ హీట్ ప్రొడక్షన్, వేడికి తట్టుకోలేకున్నా అట్లా మోర్ హీట్ విల్ బి దేర్. స్కిన్ క్యారెక్టర్స్.
హలో సార్. హలో సార్, సారీ టు ఇంటరప్ట్ సార్. అదే సార్, స్క్రీన్ షేరింగ్ ఆగిపోయింది సార్. ఇది ఓకేనా సార్?
ఓకే,
డన్ సార్.
So what is cretinism? You already know, during the intrauterine life, thyroid hormone is very much important for the neural growth, brain growth, and skeletal and muscular growth. So in that time, if there is decrease in the thyroid hormone, then it will leading to cretinism. So features of cretinism, one thing is mental retardation, another thing is discrepancy in the skeletal growth and stunted growth. It will lead to some features like next slide. Next
sir, sorry
slide.
sir, ఒక్క నిమిషం సార్.
Okay, these are the features of cretinism. What are all the features? Profound mental retardation and delayed motor development because of stunted skeletal growth, coarse hair, protuberant abdomen, and delayed closure of epiphyseal plates, and short stature, dwarfism. Here you have to look into one thing. In thyroid dwarfism, person will be having delayed mental development and profound mental retardation will be there. But in growth hormone dwarfism, there is no mental retardation. So this comparison you can see, and short stature will be there in both. Next, so thyroid. Previous slide, please. Previous slides. Thyroid. So 1 hour. So we completed thyroid hormone. So till now, what we have discussed in the thyroid? First, anatomy. Next, thyroid hormone production, where it is produced and how it will be released into the blood. Next, what is the function? Where on which it is acting. It will be important for the metabolic, increasing in the metabolic activity. This you have to remember. If you remember this, all type of the tissues and all type of the organs and system, this will help in increasing in the metabolic activity. Okay, this neuromuscular junction. Actually, it is there in the name. Neuromuscular junction between neuronal end and muscle, and transmission. Some information will be transmitted there. Through that, the muscular activity will occur. So, in this session, in this topic, we are going to discuss about structure of the neuromuscular junction and what is going on during neuromuscular transmission and what will happen if there is discrepancies in the neuromuscular transmission. So we'll go ahead. Next slide. So what is NMG? Junction between the axon terminal and muscle fiber. Muscle fibers plasma membrane, that is sarcolemma. And this resembles a chemical synapse. So neuron transmission will through synaptic transmission. Same like this is also a chemical transmission, and this transmission is called as neuromuscular transmission. Next. In that we will discuss about NMJ and what are all the events in neuromuscular transmission. Drugs enhancing or blocking the neuromuscular transmission, that we are now discussing now, and conditions affecting the neuromuscular clinical conditions. Next. Structure. What is motor unit? Actually, while I am reading this, you just remember what are all these. Motor unit. What is motor unit? Terminal botons. Actually, they are the ends of the axon terminal. Myoneural cleft. That is the distance between space between pre and post synaptic neuron. Nicotinic acetylcholine receptor. Actually, the neurotransmitter will go and attach to the receptor. We will talk about the receptors also. Motor end plate. That is the place where the neuron will attach, and post junctional fold. Actually, these are the folds of the sarcolemma. So we will discuss about each one separately, briefly. Next slide. Motor unit. Actually, what is motor unit? One motor neuron will come and it will go into the muscle, and in that muscle so many fibers will be there. So each motor neuron will divide and attach to the different, like 3 to some hundreds of muscle fiber. ये पूरा structure को one axon, motor neuron का axon and all these muscle fiber, this structure is called as motor unit. Okay, next please. botons. What is terminal botons? Actually, axon terminal. The axon at the end, it will divide into so many so many divisions, and end of the each division will form like a flattened structure, that is called as terminal botons. End of the presynaptic fibers are enlarged, forming the botons are synaptic knobs. They will be having several synaptic vesicles and mitochondria. Synaptic vesicles are containing neurotransmitter. Mitochondria will be helpful for the energy production, which will helpful for the neurotransmitter production. So you can see the synaptic botons in the diagram also. Please. Myoneural cleft. Myoneural cleft is that is the space between pre and post synaptic membranes. Presynaptic is neuroterminal. Post synaptic is myoneural membrane. Actually, muscle sarcolemma, that is actually. The space between is 20 to 40 nanometers, that is myoneural cleft, where the neurotransmitter will be released. And another thing we have to remember, in that space, acetylcholine esterases will be there. This will helpful for the production of the acetylcholine, which is released after use. So for recycling, they will be helpful. Next. Synaptic vesicles. Actually, these synaptic vesicles contain neurotransmitter, but where the neurotransmitters are produced, all the machinery for the production is there in the cell body. So they are produced there and packed there by the Golgi complex, and they will reach by traveling throughout the axon into the terminal botons with the help of what is the structure will help in the intracellular transport, that is microtubules. Through the microtubules, they will reach to the axon terminal or terminal botons. Next. Motor end plate. That is the motor end plate is the place where the neuron will come and attach on the muscle sarcolemma, thickened portion of the muscle fiber membrane at the NMJ. That's only. Next, please. You can see the diagram. Actually, I am showing these many diagrams so that you can visualize while you are studying. So while you are studying, if you visualize, it will be very helpful to reproduce the thing you have read. And post-junctional folds. Actually, if you see in the diagram, there is so many folds on the post-synaptic membrane. Actually, that is the sarcolemma is folded into so many infoldings. Actually, this will increase the number of the surface area will be increased. Actually, where the receptor for the neurotransmitter acetylcholine will be there, where the sodium channels and other cation channels will be there. Those will helpful in the transmission. Next, please. And, is this visible to everyone? The diagram is visible to everyone. Please tell. అందరికి కనపడుతుందా ఈ డయాగ్రాము పెద్దగా? యాక్చువల్లీ నాకైతే చిన్నగా కనిపిస్తుంది దీంట్లో.
ఒకసారి నేను జూమ్ చేస్తాను సార్.
ఓకే. So if we see in the diagram what is happening during the neuromuscular transmission, actually numbering is also there in the diagram. You can see number 1, motor neuron action potential. Action potential will reach this terminal button. Actually, axon terminal. After the action potential reaches the terminal, the voltage changes will be there. Because of that, voltage gated calcium channels will be opened. and opened channels will cause entry of calcium into the cell. What the calcium will cause is calcium will go and attach to the synaptic vesicles. On the synaptic vesicle, some transport proteins are there, like synaptobrevin. This will cause the activation of other proteins like syntaxin and other 2-3 proteins are there. They will cause the traveling of these neurotransmitter up to the presynaptic membrane where these synaptic vesicles are docked. It is called actually docking. After docking, they will release the neurotransmitter into the synaptic cleft. So number 3, acetylcholine is released. After the acetylcholine is released, they have to go and attach it to the receptors. Actually, receptors are having sodium channel. So sodium will enter into the cell. After that, see the step number 5. After sodium entering into the cell, some local potentials will be generated. That local potentials are actually not the action potential, but some local graded potentials. If these potentials are increased and summated to the extent that they will reach the threshold potential, then action potential will be generated in the sarcolemma. Then these action potential will travel throughout all through the cell. These are the steps happening. So step number 7 is propagation of action potentials in the plasma membrane. And step number 8. Come to the step number 8. Acetylcholine degradation. Actually, acetylcholine released and it has done its duty. After that, it should be recycled. So acetylcholine esterase will be there. It will degrade the acetylcholine and the degraded product will be utilized again for the recycling, reproduction of these acetylcholine. This is the thing what is happening in the neuromuscular junction. This is called as neuromuscular transmission. So please see the diagram, and my suggestion is whenever you are having some time, keep some time for just diagrams and flowcharts. Just one evening, sit, open your book and practice the diagram and the flowcharts. It will give a good memory में जाएगा actually. It will be very helpful. Next. So neuromuscular disorders. Actually, you already know what is happening in the neuromuscular transmission. And now you have to know about what are the disorders when there is discrepancy in the neuromuscular transmission. For example, myasthenia gravis. Myasthenia gravis, actually, this disease happened to Amitabh Bachchan. Actually, in my issue days, ma'am told this happened to Amitabh Bachchan. That's why I remembered so much. बहुत ज़्यादा याद रखा इसको, नहीं भूल गया अब तक. So myasthenia gravis, come to myasthenia. What is happening? Etiology. Etiology means you already know. Etiology is the cause of the disease. Circulating antibodies against the nicotinic type of acetylcholine receptors. So acetylcholine receptor against auto antibodies will be produced. They will destroy the nicotinic type of acetylcholine receptor. When they are destroyed, no calcium entry into that. When there is no calcium entry, no adequate graded like end plate potentials are produced. When there is no end plate potentials are produced, no action potential. When there is no action potential, no movement will occur. This is the pathophysiology behind the myasthenia gravis. Because of autoantibodies against the nicotinic type of acetylcholine receptor. Now we will see the clinical features. What is happening? Fatigue and repeated contractions. Because what is happening? Because of repeated contractions, more acetylcholine will be released. But when the receptors are destroyed, no use of releasing much of the acetylcholine, and the released acetylcholine will be destroyed by the acetylcholine esterase. Acetylcholine is releasing, but there is no use of releasing, no movement occurring because of no transmission is occurring. So there is the features, fatigue will be there, and complications whenever there is respiratory muscle paralysis, death will occur. Next slide, please. So clinical types, two types will be there. Ocular type, generalized skeletal muscle weakness will be there. Ocular type, eye muscle, actually orbicularis, ocular muscle paralysis will be there. So drooping of eye, eyeball will be there and eyelids will be there. That is called ptosis. And generalized muscle weakness. In that generalized muscle weakness, fatigue will be there. Management, ACHE inhibitors. Why ACHE inhibitors? Acetylcholine esterase. If you use that, less destruction of acetylcholine, so that prolongation of the activity will be there. That's why they will be used. Immunosuppressive. You already know why the disease is happening because of autoantibodies. So if you suppress the autoimmune causes, will helpful in डिसीज को सप्रेस करने में यूज होगा. नेक्स्ट प्लाज्मा पेरिसिस. व्हाट इज प्लाज्मा पेरिसिस? प्लाज्मा అని sieving, what is called filtering. Autoantibodies will be there. Autoantibodies from the plasma are filter. That is called plasma perisys. And thymectomy. Why thymectomy? Thymus will produce these antibodies. If you remove the thymus, no antibodies are produced. These are the, actually I am telling because if you know the reason, physiology behind that, you can understand the treatment easily. Next, please. The diagram also you can see what is happening there. Next, please. Lambert-Eaton myasthenic syndrome. In this, actually, this is also an autoimmune disease. This is also an autoimmune disease where the autoantibodies are produced against the voltage-gated calcium channels. You know already voltage-gated. See in the diagram. Voltage-gated calcium channels are there in the presynaptic membrane. When they are destroyed, no entry of calcium into that. When there is no calcium entry into the cell, no synaptic vesicle into the towards the presynaptic membrane, no release of acetylcholine. So there is difficulty in neuromuscular transmission. That is what happening there. And treatment, same treatment. Plasma perisys, IV immunoglobulin, prednisolone. Prednisolone is actually the immunosuppressant. Next, acid-base balance. So till now we discussed about neuromuscular transmission. In that neuromuscular transmission, what we discussed? Anatomy of neuromuscular junction. Next, what is happening there? That means neuromuscular transmission, steps of neuromuscular transmission. And if there is any discrepancy in that or disorders, they will lead to neuromuscular disorders like myasthenia gravis. Myasthenia gravis is because of antibodies against nicotinic type of acetylcholine receptor on the postsynaptic membrane. So because of that, no ACH, no transmission of the neuromuscular through the neuromuscular junction. And another one is Lambert-Eaton syndrome. In these antibodies against voltage-gated calcium channels, which are helpful for the transport of the synaptic vesicle. So there is also no transmission is occurs. This is causing, actually these are the disorders of neuromuscular junction. Next, acid-base balance. एसिड बेस बैलेंस नाम में है. एसिड क्या है? सो पहले एसिड के बारे में, सॉरी, so now first we will discuss about what is acid briefly. Actually you already know what is acid since childhood you are reading, but just for revision we will see what is acid, what is base. After that, all the systems helping in the body to maintain the acid base balance, like what is buffer system and how the respiratory system will be helpful in the to prevent the changes in the pH or acid concentration in the body, and how kidneys are helpful in these, and what are all the disorders regarding that, like acidosis, alkalosis, respiratory acidosis, respiratory alkalosis, same as like metabolic acidosis, alkalosis. These are all the things we're going to discuss. So first, what is acid? Usually acid is a substance containing H plus and it can release H plus into the solution. For example, HCl, H2SO4. Physiologically important acid. Actually, all these physiologically important acids are producing continuously inside the body. For example, carbonic acid, phosphoric acid, pyruvic acid, lactic acid. Pyruvic acid and lactic acid, during the cell metabolic activity, glucose activity, these are released. Next. Base. Acid is which can release the H plus ions. Base is which can accept the H plus ion. For example, sodium hydroxide, potassium hydroxide, and ammonia, sodium bicarbonate, all these are bases. So actually I forgot one thing. What is strong acid? What is weak acid? Strong acid will readily can divide it into the ions. It will able to give the H plus ions. Same wise, strong base, weak base. A strong base actually it will readily divided into you can see here base plus OH minus. Weak base weakly divides and there will be equilibrium between the base and its ions. And physiologically important bases are bicarbonate, biphosphate, and proteins are the important bases in the body. Next. Hydrogen ion concentration. Actually, normally in the body, hydrogen ion concentration is 0.000004 equivalents per liter. Actually, writing this every time is cumbersome process. So, scientists invented some metrics to denote the hydrogen ion concentration, like pH scale. Simple pH scale. What is pH? pH is the negative logarithm of hydrogen ion concentration. So they are using this scale for the easily denotation of this hydrogen ion concentration. You know what is pH? Negative logarithm of H plus. What is the normal plasma pH? That is 7.4. High pH means low concentration of H plus. Low pH means high concentration of H plus. Next. The same one, which is the negative logarithm of hydrogen ion concentration. Neutral pH is the pH of the water is 25 degrees centigrade, where H plus and OH are equivalent numbers, and arterial blood pH is 7.4, venous blood pH is 7.35. If you observe, a little less will be there. Why it is a little less? Because of more carbon dioxide will be there. Because of that, pH is little decreased. Because of carbon dioxide, a little increase in the H plus ions. What is the relation? You can see in the next slides. And urine pH is 4.5 to 8.0. Gastric acid pH is 0.8. Actually, it is better to remember all these four values. What is blood pH, venous blood pH, urine pH? These are the things. Acid-base balance. Next. What is acid-base balance? These H plus ion concentration should be kept in normal range. What is normal range? 7.35 to 7.45. This is the normal physiological range. Body is always trying to keep the H plus ion concentration in this range only. And if it is more than that or less than that, it is lethal to the tissue. Because next, Importance of acid-base balance. Why it should be maintained in the physiological range? Because for the proper enzyme activity, it should be in physiological range. Maintenance of the protein structure, normal cellular metabolism, maintenance of electrolyte balance, normal functioning of organs like heart, brain, muscle, and prevention of acidosis and alkalosis. So by this you understand that for every physiological activity, pH maintenance is must. For that, system is continuously doing this acid-base balance. Mechanism of pH maintenance. Chalo, next. Mechanisms of pH maintenance. All the mechanisms are helping to keep this pH in normal range. One is buffer system. Another is respiratory mechanism. Another one is renal mechanism. So let us discuss all this. Next, buffer system. Actually, what is buffer? Buffering is resisting the change. So here what is happening? Buffer is the substance that has the ability to reversibly bind or release the H plus in the solution. It keeps the pH of the solution relatively constant. Actually, the thing is the substance which can resist the change in the pH of the substance. That is the buffer. How buffer will work? Buffer will attach to the H plus whenever needed, and it can release the H plus whenever needed, so that it will help in the resisting the change in the hydrogen ion concentration. So here some points are there. Buffer cannot remove H plus ions from the body, only temporarily reduce the free H plus ions. Yes, it will be attached to the H plus, and H plus ions have to be ultimately removed by the renal mechanism only, because of buffer system can't remove from the body, and they exchange a strong acid or base for a weak one, and this results in a much lesser change in the pH. Actually, what is happening? Buffer will go and attach to any acid or strong acid or base. It will convert it into weaker acid or base, which will helpful in the decreasing in the change in the pH. That is what happening. Next. So buffer systems in the body. Buffer systems in the body, one in ICF, intracellular buffers and extracellular buffers. Intracellularly, most important buffer is phosphate buffer. Along with that, hemoglobin is also a buffer, which is there in RBC. And proteins are both intracellular and extracellular buffers. And carbonic acid is the most important extracellular buffer, and plasma proteins also will be there, which will helpful at the buffer. So this diagram, if you remember the diagram, it will helpful. Intracellular, extracellular, water, all those. Next. Bicarbonate buffer. In bicarbonate buffer, sodium bicarbonate, actually components of that bicarbonate buffer are sodium bicarbonate and carbonic acid. They will maintain in a ratio of 20:1 ratio. And actually what is happening, whenever you add a strong acid to the buffer system, some component of that buffer system changes that strong acid components into some weak acid, so that change in the pH will be reduced. Minimum change in the pH will be there. For example, HCl plus sodium bicarbonate will form H2CO3, which is a weak acid. Similarly, sodium hydroxide and bicarbonate, they will form sodium hydroxide and carbonic acid. They will form sodium bicarbonate, which is also a weak acid. So through this mechanism, they will help to actually resist the changing in the pH. Next. You can see in this equation, please show that show that one, previous one. Actually, in this you can see, ultimately, buffer will produce some weak acid. Weak acid, if you see in the weak acid, H2CO3 will be in equilibrium in the reactions, like it will react with water to form carbon dioxide, and another side it will react with H plus forming bicarbonate. Eventually, they can be excreted through like renal excretion and respiratory expression ke through it will be sent outside. Actually, whenever something is causing changing in the pH, it will causes production of a weak acid, and weak acid will be react with some substances which will produce some other substances with which body can easily regulate, like it will lead to production of carbon dioxide, so lungs will send it out, and bicarbonate, renal regulation, like kidneys will send it out. So Henderson Hasselbalch equation, you know what is this? Already so many times you have seen, you have written. So just this equation is used to calculate the pH of the buffer solution based on the concentration of weak acid and its conjugate base. pH is equal to pK plus log A minus by actually anion by the acid. What is the importance of this? Help to determining the appropriate ratio of acid to the conjugate base needed to achieve a. Actually, this is more important in chemistry. To attain this pH, how much of acid should be added to the solution? To calculate this equation will be helpful. If you apply to the body biological systems, it will be helpful to measure the pH of the biological solutions. Next. Phosphate buffer measure intracellularly. You already know it is measure intracellular buffer. Whenever something is added to that, it will eventually produce a weak acid that can be excreted. Actually, whenever you add something, the buffer system will attach to that, and it will produce some other substance which can be easily manipulated by the body. So here phosphoric acid will be produced that can be easily excreted by the body, and its pK is 6.8. So it will be powerful buffer, actually it is, and most efficient in renal tubules and ICV. You already know what is happening in the renal tubules for the excretion of hydrogen ion. This phosphate buffer is useful. Next. Protein buffer. Actually, proteins are so very powerful buffer. They can actually, hydroxyl group can give H plus, amino group can accept H plus. Through this property, protein will help as powerful buffers. That's only, and ICF buffer is 60 to 7%. That means intracellularly 60 to 70% of the buffer activity will be done by proteins only, so that they will help in resist the change in the pH. That's next. Respiratory mechanism. So you already know bicarbonate buffer. Bicarbonate buffer, what it will cause? It will eventually produce carbonic acid. Carbonic acid, whenever it is reacted with the water, it will form carbon dioxide. Okay, this carbon dioxide will be easily exhaled by the lungs. So the respiratory mechanism is retaining or excreting out of the carbon dioxide. That's what happening in the lungs. Whenever there is carbon dioxide increased, it will cause the stimulation of brain center, respiratory center. It will cause increasing the respiratory rate. If the respiratory rate is increased, more carbon dioxide will be washed out. And whenever there is decreasing in the carbon dioxide concentration, it will lead to decreasing in the respiratory rate, it will lead to retaining of the carbon dioxide. So that carbon dioxide concentration will help in maintaining the pH. That is what happening in the respiratory mechanisms. Next, renal mechanism. So you already know what is happening by bicarbonate buffer. It will produce the bicarbonate ions actually, which is the base on the concentration. If it is increased, it will be excreted by the kidney, and when it is decreased, then it will cause preservation and less secretion of the bicarbonate by the kidney. So this is how kidneys helps in acid-base balance. Kidneys also secrete H+ ions. So how kidney is helping? Whenever there is increasing in the H+, it will secrete more H+. Whenever there is decreasing in the H+, they will preserve the H+ by decreasing in the secretion. And if you see the bicarbonate, whenever there is increasing in bicarbonate, kidneys will secrete out that bicarbonate. And whenever there is decreasing in the blood, it will secrete. They can produce the new bicarbonate and decrease the secretion of these bicarbonate. So this is how lungs will work. Next, rate of correction. Actually, he is telling about the power of capacity of buffering capacity of each system. So you know already buffers are first reaction, first instantaneously they will react, but they are not much powerful, and some short term they will work for short term. And respiratory mechanisms, this will start in minutes to hours. And renal mechanism, actually these are the ultimate mechanism, powerful mechanism, but they will start acting lately, like hours to days they will start. Next, acid-base imbalance. What is acid-base imbalance? We have discussed about what is acid, what is base, how much base should be there. Base should be there in between the range of 7.35 to 7.45. When there is decreased than that, it is called acidosis. Increased than 7.45, that is alkalosis. Whenever there is increasing happening, body will, as a reaction, do some compensatory mechanisms, and those compensatory mechanism will be complete or sometimes partial. That will be there. If we see in the diagram, accumulation of the acids, H+ ions increase, and loss of the base. So base content is decreased. It will lead to increasing in the H+ ion concentration. There is increasing in the H+ ion concentration, increasing the pH will be there. That is called acidosis. Next, decreasing in the concentration, it will lead to alkalosis. Next, compensation. As a compensatory mechanism, depending upon the underlying mechanism. If it is metabolic problem, then metabolic problem means the concentration of bicarbonate in the blood is increased or decreased, then respiratory compensation will be there. The problem is respiratory, renal mechanisms, and metabolic compensations will be there. You will see what is that in the next slides. Acidosis, you already know, decreasing in the pH is acidosis, and in metabolic acidosis, bicarbonate concentration is decreased. In respiratory acidosis, increasing in the carbonic acid, and metabolic alkalosis, increasing in the bicarbonate, and respiratory alkalosis, decreasing in the carbonic acid. So you already know acidosis means decreasing in the pH because of either increasing in the acid or decreasing in the base. And alkalosis means increasing in the base, that is either because of increasing in the production of base or loss of acid. And alkalosis, actually, if the body is unable to keep these in the equilibrium like homeostasis, there will be some disorders. In some disorders, these alkalosis will occur. In alkalosis, the symptoms will be excitability of the nervous system. Person will be nervous, muscle spasms will be there, and it can lead to convulsions also. Next, acidosis. Acidosis. In acidosis, CNS depression will be there, generalized weakness will be there, and deranged CNS functions. The greatest, actually, it is the greatest threat will be there. This is what happening. And respiratory acidosis. You already know what is name. It is there. Respiratory acidosis. Acidosis means increasing in the acid. Respiratory means respiratory component is carbon dioxide. Whenever there is increasing in the carbon dioxide in the blood, it will lead to respiratory acidosis. When it will happen? In conditions like depression of the respiratory center. If respiratory center is depressed, respiratory rate is decreased. When rate is decreased, carbon dioxide is accumulated. And paralysis of the respiratory and chest muscle. This will also lead to decreasing in the respiratory rate. COPD. What is COPD? COPD is chronic obstructive pulmonary diseases. What is happening in that? In COPD, person is able to inhale, but there is obstruction during exhalation. So because of that, so much of carbon dioxide will be accumulated in the lungs and eventually in the blood. Adult respiratory distress syndrome. This is also leading to the increasing in the carbon dioxide concentration in the body. If you see in the diagram, he is telling respiratory failure, increasing in the PCO2. Whenever PCO2 increases, pH decreases, that is respiratory acidosis, and as a compensatory mechanism, bicarbonate will be increased. If it is not sufficient to restore the pH, you should give some treatment. Actually, what he is telling, body will try to compensate by increasing in the bicarbonate. You already know, for respiratory acidosis or respiratory disorder, there will be metabolic compensatory mechanism. So kidneys will help to increase the bicarbonate. And next, respiratory alkalosis. In name it is there. Alkalosis means either increasing in base or decreasing in acid. Here respiratory means carbon dioxide will be there. Carbon dioxide ka is PCO2. If PCO2 is less than 35 mmHg, then respiratory alkalosis will occur. Most common causes hyperventilation. Hyperventilation means increasing in respiratory rate. When respiratory rate is increased, more carbon dioxide will be washed out. So decreasing in the carbon dioxide concentration. That will happen when oxygen deficiency at high altitudes. So you know high altitude physiology. In high altitude, hyperventilation will be there because of stimulation by hypoxia. So when hypoxia will come, it will cause increasing in the respiratory rate. That is called hyperventilation. Because of hyperventilation, more wash out of CO2 will be there. Next, pulmonary disease and congestive heart failure. In this also, hypoxia will be there. That will lead to stimulation of respiratory center. That will cause more wash out of CO2. And acute anxiety. In anxiety also, in anxiety also there will be hyperventilation. Because of that, more CO2 washout will be there. And as a compensatory mechanism, kidneys conserve H plus. Previous slide, please. Compensatory mechanism, kidneys conserve H plus and excrete the bicarbonate ion. Next. metabolic acidosis. In name it is there. Acidosis means either increasing in acid or decreasing in the base. Metabolic means metabolic components is bicarbonate. When bicarbonate is decreased, then the normal value, that is metabolic acidosis, causes diarrhea. In diarrhea, what is happening? All these bicarbonate ions are go through the this in diarrhea and in renal function. In renal dysfunction, when renal system like kidneys are damaged, they are not able to preserve the bicarbonate ions and they are not able to secrete the extra bicarbonate ions. So blood bicarbonate will be decreased. Then this situation will occur. And accumulation of acids like lactic acid or ketones. This will happen in diabetic ketoacidosis. You know what is happening in diabetic ketoacidosis? More ketone bodies like acetone and beta hydroxybutyrate and acetic acid will be produced. So acid accumulation will be there. Failure of the kidneys to excrete H+. So kidneys will also do the important work is H+ excretion. When kidneys are damaged and they are not able to excrete these H+, this metabolic acidosis will occur. Actually, this is a very dreaded condition, medical emergency. So immediately there should be treatment, and body as a compensatory mechanism, it will cause increasing in the ventilation and renal excretion of hydrogen ions if possible, and K+ exchange will happen, and as a treatment lactate solution will be given. Next, is it okay? Sorry, metabolic alkalosis. In name it is there. Alkalosis. Metabolic means bicarbonate. Increasing in the bicarbonate causes vomiting. In vomiting, what will happen? A substance in the stomach will be thrown out. In stomach, HCl will be there. So HCl also will go out. So it will cause increasing in the H+ and increasing in the bicarbonate. And excessive use of alkaline drugs like you will use alumina magnesia. If you use these drugs more, it will cause increasing in the bicarbonate. Heavy ingestion of antacids, same that what I told now. If you having a habit of increasing use of antacids, then also it will occur. Severe dehydration, in this also this will happen. So alkalosis most commonly occurs with renal dysfunction. So can't count on kidneys. Actually, metabolic alkalosis will happen because of kidney disorder, and respiratory compensation is also difficult. So this is also a medical emergency. Immediately you should give the treatment. Next, arterial blood sample. If you know the blood sample, actually, if some person is came with some acid-base disorder, you suspected acid-base disorder, then how you will diagnose which type of acid-base disorders? First, you will see the pH. If pH is less than 7.4, if it is less than 7.4, it is acidosis. So in acidosis, two types will be there: metabolic, respiratory. If it is in metabolic, you already know in metabolic acidosis, decreasing in the bicarbonate, and it will lead to, it will cause body will do some compensatory mechanisms by respiratory compensation. In that, CO2 will be PCO2 will be increased, and in respiratory acidosis, you know, CO2 will be increased. When CO2 will be increased as a compensatory mechanism, renal compensation should be there, so it will increase bicarbonate. Similarly, if the pH is actually while I am telling you, observe, you people observe in the diagram what I am telling. Okay, in pH, if the pH is greater than 7.4, it is called alkalosis. What is alkalosis? Alkalosis means increasing in the bicarbonate or decreasing in the acid. When it is increasing in the bicarbonate, in metabolic alkalosis, body will show the respiratory compensation by increasing in the PCO2 concentration. And similarly, if it is the respiratory alkalosis, in respiratory alkalosis, PCO2 is decreased. As a compensation mechanism, body will cause renal compensation, decreases the bicarbonate. This is how you can interpret and diagnose the acid-base disorders by using the ABG. You know what is ABG? Actually, in your internship, you take so many ABG samples, like you have to take blood from the artery. Usually, you take for the test, you will take from the veins, but for ABG, you will take the arterial blood samples and you will send to the analysis. There, you will get all these values, like how much is the pH, how much is the bicarbonate, how much is the PCO2, like all these values you will get. By seeing these values, you have to diagnose which type of acidosis or alkalosis is there in the patient. For this will be helpful. So this is how to interpret and diagnosis. Next. All the best. Okay. Actually, what we have discussed in acid-base balance, what is acid, what is base, and in the body, acid will be continuously produced in the metabolic activities. Continuous acid will be produced. That produced acid should be, that acid's concentration should kept in the physiological range. To measure the range, we will use the pH scale. In the pH scale, normal blood plasma pH is 7.4 and the physiological range is 7.35 to 7.45. Body should always doing things to keep the pH in physiological range. To keep the physiological range, some physiological mechanism will be there. And those three systems will be there: buffer system and next respiratory mechanism and renal mechanism will be there. In buffer system, intracellular buffers are there, extracellular buffers are there. Intracellular buffers, most important is phosphate buffer. Along with that, proteins are the important buffer. For example, hemoglobin. And extracellular buffers, proteins acts as extracellular buffers also. And most important extracellular buffer is bicarbonate buffer. Another, proteins extracellularly, proteins also acts as buffer. These are the buffer system. In buffer system, bicarbonate, all these buffers. Next, respiratory mechanism. Respiratory mechanism, lungs control the concentration of CO2 by increasing or decreasing the respiratory rate. If it is increasing the respiratory rate, more washout will be there. If there is decreased, then preservation of CO2 concentration will be there. Next, renal mechanism. Renal, kidneys, what kidneys will do? Secretion of H plus or preservation of H plus, secretion of bicarbonate or production of bicarbonate, preservation of bicarbonates. By all these mechanisms, body is going to keep the acid-base concentration in the physiological range. This is what the acid-base balance. I think this session is helpful to you, and sorry for the inconvenience caused in between. Actually, it should be completed in 1.5 hours, but it took time because of some technical issues, and that's the thing. Thank you. Is there any doubts? And another thing, if you want me to explain any other topic also, you can ask me. I will prepare it and I will explain it.
Hello sir, thank you for your session sir. I guess doubts ఏం లేవనుకుంటా సార్, చాట్ బాక్స్ లో ఎవరేం పెట్టలేదు.
పిల్లకాయలు కూడా ఎవరు లేనట్టు
సార్ అంటే అదే సార్, అలా అయిపోయింది సార్.
No problem. I think ఉన్న వాళ్ళకి యూస్ఫుల్ అయింది అనుకుంటా.
అవును సార్. అండ్ ఆల్సో రికార్డెడ్ సెషన్ మళ్ళీ యూట్యూబ్‌లో కూడా అప్‌లోడ్ చేస్తాం సార్. సో, అలా కూడా మిస్ అయిన వాళ్ళు ఇదవ్వచ్చు సార్.
ఓకే. ఓకే. థ్యాంక్ యూ.
సో, కంక్లూడ్ చేసేసానా సార్?
అయిపోయింది కంక్లూజన్. యాక్చువల్లీ అంటే ప్రతి టాపిక్‌ని ఎవ్రీ టాపిక్ యూ షుడ్ రీడ్ అండర్ సమ్ హెడ్డింగ్స్ దట్ విల్ హెల్ప్‌ఫుల్ ఫర్ యూ. అండ్ diagrams and flowcharts are must in physiology. So prepare for that. తెలుగులో ఉన్నారు కదా, if you actually keep some time while preparing, keep some time for only diagrams and flowcharts, that will be very helpful. Actually, while my PG examination also I did this, that was very helpful to me. I suggest that. Okay, thank you.
As we come to the end of today's session, we extend our heartfelt gratitude to Dr. Siva Sankar sir for an insightful and enriching session. Thank you, sir, for your valuable time, guidance, and unwavering support. We also thank all the participants for their presence and active participation. Let us end the session with Shanti Mantram. Om Sarve Bhavantu Sukhinah, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kaschid Dukkha Bhag Bhave. Om Shanti Shanti Shanti. Thank you, sir. Once again, I'll end the session, sir.
Thank you.